I'm Bajaj, and I'm a plastic surgeon in private practice in Oklahoma City. I have been asked to discuss the article, Race and Breast Cancer Reconstruction. Is there a healthcare disparity? The authors attempt to evaluate if healthcare disparities exist in women undergoing breast reconstruction. They categorize the types of reconstruction based on CPT code as implant-based, autologous tissue-based, which is reconstruction using one's own tissue, or other. A total of 2,533 patients were included in the study, of which 82% were Caucasian and 14% were African American. The remainder were Asian Pacific Islander, Hispanic, or unknown. Median household income for these women was about $49,000, and as a whole, 67% of these women underwent implant-based reconstruction, and 18% underwent autologous tissue-based reconstruction. When comparing the Caucasian and African American women, the authors found that the African American women were more likely to have Medicaid, had a lower overall charge to insurance company, and also tended to live in a zip code with a lower median income. Medically, these women were also more likely to be active smokers, to have diabetes, and to be obese. The authors were able to demonstrate that in their cohort in St. Louis that African American women were more likely to prefer autologous tissue-based reconstruction. Some of the limitations of this study, which the authors do mention, include the fact that they did not account for the education status or awareness of breast cancer or breast reconstruction in their patient population, and that the data is from a single institution, which is a tertiary referral center, and this may limit its generalizability. The causes of these racial disparities are multifactorial. The authors explain that these disparities can be provider-based. For example, physicians may treat African American women differently, or they can be patient-based, meaning that African American women may prefer autologous tissue-based reconstruction based on their values, or the disparities can be systems-based. In other words, African American women may have lesser access to care. The authors hypothesize that their findings are primarily due to patient-based factors. Some of these women may favor autologous tissue-based reconstruction to avoid long travel distances, make fewer trips to the doctor, and to rid themselves of an abdominal pannus. While implant-based reconstruction is the most common type of reconstruction performed nationwide, a preference for autologous tissue-based breast reconstruction by African American women is not a bad thing. Other studies have shown that women who have autologous tissue-based breast reconstruction have better long-term satisfaction when compared with implant-based reconstruction or no reconstruction at all. The Women's Health and Cancer Rights Act of 1998 made it a federal law that private insurers provide coverage for breast reconstruction. The intent of this act was to help remove some of the financial barriers that women may encounter when considering breast reconstruction. More recently, the Breast Cancer Patient Education Act was passed in 2015. The purpose of this act is to implement an education program to inform women of options regarding the availability and coverage of breast reconstruction after cancer. As more women become aware of their options regarding breast reconstruction, the hope is that these racial disparities will become less significant. Meanwhile, studies such as this one are informative and allow us to better understand these disparities so that we can work to eliminate them.